I'm not suggesting advocating this mobile app. People can use this mobile app for a speaks out. Also helpful to keep all those pictures. This is one app which is available free right now. This is very user friendly. That's inbuilt optional intraoperative images, especially depending upon the various risk and who whatever portion you want to see. It helps you easily mount this thing. It has a background. All these data are saved in the cloud. You can get back all those pictures with the same quality. So I only prefer a laptop. I don't want to save all these things to print. You can do it in the laptop. Video also save in the laptop. So I advise you to keep in a folder. So for example, I have folders from 2009 to till date. Keep it in a separate year folder. Open that separate folder. Have it in a separate title. Can be regular plexus, can be hand injuries, can be scaphoid. Once you open it, keep all those folders in the palm of the name, and then you can get all those pictures. So with this, I'll end my talk. Probably can take some questions. So data saving is very important, and it's also helpful in getting back to have your articles
Hello. Okay. Hello. Good morning. Hello.
Morning. Good morning. Morning. இப்ப எல்லாம் ஒழுங்கா எடுக்குதா ஆடியோலாம்? ஹலோ வர மாட்டேங்குது. வருது. ஆடியோ வருதா?
சார் இல்ல சார் இதுல புரியாத வருது சார். ஹலோ சார் இப்போ கேட்குதா சார்? ஹலோ சார் குட் மார்னிங் சார், இப்போ கேட்குதா சார்? கேக்குதுல
ஆ
சார்? சார் மார்னிங் சார், கேக்குதா?
மார்னிங் கேக்குது.
சார் மார்னிங் சார், சரவணன் சார் மார்னிங் சார்.
மார்னிங் சார், டாக்டர் சரவணன்.
Morning, sir. Morning.
Good morning. Good morning.
சார் குட் மார்னிங் சார், ஜாய் சார் குட் மார்னிங் சார்.
Dr. Muthamani, how are you?
சார் ஃபைன் சார், நல்லா இருக்கீங்களா சார்?
Yeah, nice to see you.
சார் தேங்க்யூ சார்.
குட் மார்னிங் சார்.
சார் ஸ்டார்ட் பண்ணலாமா சார்? வெயிட் பண்ணலாமா சார்? ஸ்டார்ட் பண்ணலாமா சார்?
ஸ்டார்ட் பண்ணலாம் சார். 7 o'clock ஆச்சு.
ஏன்னா இன்னைக்கு ஸ்டேட் கவுன்சில் மீட் நடக்குது சார் ஐஎம்ஏல, அதனால நிறைய பேர் அங்கே போயிட்டாங்க சார்.
ஓ, மார்னிங் நடக்குது, ஈவினிங்?
இல்லை சார், இது லைவ் மீட்டிங் சார், நேராக போயிருக்காங்க சார். நேற்று ஈவினிங்கே நிறைய போயிட்டாங்க.
எங்க நம்ம திருச்சிலையா?
திருச்சியில் இல்லை சார், இது கள்ளக்குறிச்சின்னு நினைக்கிறேன் சார்.
ஆமாம், சொல்லி சார். வில் ஸ்டார்ட் சார்.
ஓகே சார்.
9:30.
Good morning, one and all. I welcome you for this month API monthly meeting. As usual, this month also we have got two topics. One is from Dr. Joy Varghese sir, and another one is from Dr. Saravanan sir. The continuation of previous CBC talk. Physician prayer. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray that you give skill to my hand, clear vision to my heart, and strength to my body. I pray that I will always realize that being a physician is a privilege and honor. With the simple faith of a child, I will rely on thee. Amen. I request our chairman, Professor Sivasankaran sir, for the welcome address.
Good morning to everyone. On behalf of our APA chapter Trichy branch, I cordially welcome our two eminent speakers, Professor Saravanan, MD from Coimbatore, is going to continue the TBC part 2, the count that counts. The next topic is Dr. Joy Varghese from Chennai, who is going to talk about non-alcoholic fatty liver disease, facts and fallacies. And also welcome to all our senior members of APA and other branches. And over to our secretary to continue the session.
So minutes of the previous meeting. February month meeting was held on 27th on Zoom platform. Around 120 participants attended the meeting. The lecture was accredited by TNMSC for 1 credit point. We had two topics. The one topic is Approach to Peripheral Neuropathy by Professor Dr. K. Mukundan, HOD Department of Neurology. Now he is in Stanley Medical College. And next topic is ECG Findings in Neurology by Dr. P.V. Balamurugan, Associate Professor, Government Sivagangai Medical College. We had a lively discussion about both the topics, and hopefully we will be conducting our next APA meeting as a live meeting. So going into the academic session, the first topic is from Dr. Joy Varghese sir about the non-alcoholic fatty liver disease. He is the Director of Hepatology and Liver Transplantation. He is presently working as the Director Hepatology and Liver Transplantation in Gleneagles Global Hospital, Perumbakkam, Chennai. He has more than 20 years of extensive experience in the field of gastroenterology and hepatology. He has vast experience in managing both medical and surgical liver ICU patients. He is one of the very few initiators in the world for therapeutic plasma exchange role in liver disease management. More than 600 adult liver transplant perioperative and long-term management. He also worked as a visiting consultant in the renowned hospitals like MMC and Kumaran Hospital in Chennai. He is a member of teaching faculty in the Department of Hepatology, Government General Hospital, Chennai, and Institute of Liver Transplantation in Government Stanley Medical College, Chennai. He has played a vital role for setting up cadaver liver transplant program in various hospitals in Tamil Nadu and Kerala states in both government and non-government sector. He has published more than 60 research articles in the field of hepatology and liver transplantation in the index journals and written many chapters in the renowned books. He has been serving as an editorial board member of the World Journal of Hepatology and Global Journal of Gastroenterology and Hepatology and reviewer board member for various international and national journals. He received fellowship in transplant hepatology at University Hospital, Germany. So with this introduction, I request Dr. Joy Varghese sir to take over the session.
Thank you, Dr.
Thank you.
So good morning to all. So, my sincere thanks to all the APA Trichy branch physicians, senior professors, and Dr. Muthamani and Dr. Shivashankaran for the kind invitation for this on Nafld. It's visible now.
Visible, sir.
Visible, sir. Visible, sir.
So, what is the important to know about the Nafld? So today the topic on the non-alcoholic fatty liver disease. Why we have to worry about Nafld related? So it is the increasing the leading cause of liver disease. We all know alcohol was considered as the most common cause of liver disease. If you look into that, the recent literatures, Nafld, non-alcoholic fatty liver disease, comes as the leading cause of chronic liver disease. Second, we thought, now India also mostly are thinking the alcoholic liver disease, the one of the common indication for liver transplant. Of course, it is still the leading cause, but nowadays we started to see non-alcoholic fatty liver disease related the reason in male, female, and all the, even in pediatric also associated with other genetic diseases are coming in the leading cause. The recent literatures, if you look at the graph, so the green color indicates the Nafld, non-holic fatty liver. So compared with the 2002, in 2018, this non-communicable chronic liver disease is increasing, and second, that alcohol, other chronic hepatitis B, C, autoimmune, PSC. So everything is more or less in the last 20 years, the prevalence is almost the same. This is the graph which shows the indication for transplant. The first one, there is a hepatitis C virus, the pink color, what we are seeing, the pink color, this is a hepatitis C virus. Due to the good antiviral drugs, now the alcohol, still it is the high, but if you look that non-alcohol, the green curve, it's catching up. And it's a prediction that in 2030, in world, non-alcoholic fatty liver will be the most common indication for liver transplantation and the most common chronic liver disease. So that's why in the next few minutes, we are going to have a look out. So how, so that its history and the epidemiology and what is the definition, even though we know all the non-alcoholic, just, I mean, I wish to go through that, the order of pathophysiology and the clinical features, diagnostic and the scoring system, management, and the current trends and future consideration. 40 years ago, the Ludwig diagnosed histologically the similar picture what the alcoholic people will have the changes. The same thing he noticed in non-alcoholic liver patient. That time he put it non-alcoholic steatohepatitis. Still the same, the terminology we are using, non-alcoholic steatohepatitis. It looks like a inflammation in the liver. The inflammation related fibrosis, at one end cirrhosis. So it's if you look into the epidemiology, this non-alcoholic fatty liver disease is parallelly increasing in obesity. So nowadays, obesity is one of the common feature in worldwide, and in the children also, that obesity play a major role. Whenever the obesity increases, and that time the parallelly with the non-alcoholic fatty liver disease will increase. And now it is called as the hepatic component of metabolic syndrome. The terminology also, earlier we used to say NASH, non-alcoholic. Now they are started to mention MASH, metabolic associated steatohepatitis. So in the metabolic syndrome, whatever the component we know, now they are incorporating the hepatic component of the metabolic syndrome is the Nafld. So it's called syndrome X. So not only obesity, there is still chances are there. 7 to 10% of the normal weight individual also, we can notice the ultrasonogram wise the NASH. And if you look into that, what about the acute, the prevalence of the disease, it's totally difficult because it will not cause any symptoms at the initial stage. Only using the investigations, we can come to know the early stage of the Nafld or the early fibrosis. Once the advanced fibrosis sets in, then you can easily diagnose. The patient also will start to develop the symptoms. If you look into the global prevalence, it varies from 13% to 30%. But if you look at India, surprisingly, based on our data, it varies from 9% to 53% of the Indian population. I will show the next slide. So in general, what we can understand, the Nafld is becoming as a epidemic disease in near future. So it's a various countries. What about the Nafld prevalence? If you look into that, the gene which is involving Nafld, the PNPLA3. So in India, that gene related, the PNPLA gene related, the incidents, the associations are more. So what is the importance of the PNPLA gene? It is coming into the therapeutic point of view. So I already mentioned the India, the statistic shows there is a wide variation from 9% to 53%. If you look into the north, particularly Delhi and Chandigarh, that belt, Punjab, everything shows the very high prevalence compared with other. But if you look here also in the Kerala and in the Tamil Nadu and the Pondicherry, this belt, here there is a slightly variation, but still these all multiple factors will influence this kind of the epidemiology studies. But what we can understand, it is the Nafld is very common in India. So what is the definition of Nafld? We can accept up to the 5% of the fat within our liver. Whenever the percentage of the fat component goes more than 5%, that is called fatty liver. So this fatty component, it can be there as a simple fat. Sometimes it will associated with the insulin resistance. So that's why it comes as a MASH, metabolic associated steatohepatitis, and that is the hepatic component of the metabolic syndrome. So how we can identify the percentage of the fat component within the liver? One is the liver biopsy. But without liver biopsy also, that is called liver biopsy called histological analysis. Without liver biopsies also, we can approximately estimate the fat component either by the CT scan or MRI, that's called MR elastography, or MR fat fraction machines. This all the software wise we can estimate indirectly. And whenever we identified the fat component, we have to rule out associated alcoholic fatty liver disease, because alcoholic people is commonly the liver initial phase will be the fatty liver. So what is the quantification here to define as alcoholic fatty liver diseases? In a man, so more than 30 grams. In a woman, it's more than 20 grams per day. So if a patient has a living history of beyond this limit, the alcohol consumption, we shouldn't label as a Nafld. We are Nafld. We have to call it as alcoholic associated fatty liver disease. This non-alcoholic fatty liver disease is a spectrum of the disease. As I already mentioned, though it is the prevalence is very high, it is not causing all the patients, all those who have the positive are not suffering by diseases. So the prevalence is high, but the disease rate, if you look into that, it is comparatively less. What could be the reason? Most of us that will be in the initial phase of simple fatty liver, because that means there is no much inflammation, very, very mild inflammation. That time, the disease progression rate is significantly low. Once this mild lobular inflammation extends to the moderate or severe, that is called NASH. That time, if you do the liver biopsy, we can see multiple, the polymorphonuclear cell infiltration and the lymphocyte infiltration in the portal triad and the central lobules. So based on that inflammation, so that the consequences, it comes as a fibrosis, early fibrosis, and advanced fibrosis. At one time it goes to the cirrhosis. So the NASH consists of in clock 2, there is F1 to F4. Once the cirrhosis sets in, there is a chances 5% of the people to develop hepatocellular carcinoma. So there's no need of cirrhosis. If you see that picture, we can see any grade of fibrosis that can lead to hepatocellular carcinoma. In our day-to-day practice, we are seeing a patients coming with the HCC in the absence of hepatitis B virus or hepatitis C virus, and the liver will be absolutely normal. But if you go through that, they will have the associated fibrosis, either due to diabetes related, NASH related fibrosis background, or sometimes they will have the inflammation, even the grade 1. So HCC can occur in NASH, not only with the B virus, C virus, alcoholic cirrhosis. So what are the risk factors? So how we can predict who are the more prone to get the Nafld or Mafld? So it is like a metabolic syndrome component. Those who have a diabetic or genetic obesity, that plays a primary risk factors. It includes insulin resistance, dyslipidemia, etc. If you look into the secondary risk factors, like a polycystic ovarian syndrome, and a certain medication will increase, and a certain drugs and the gender also, particularly female. So what are the pathophysiology? So how this risk factor, whatever I have mentioned, primary, secondary component, will lead to the NASH or cirrhosis. This was, the two-hit hypothesis was described by Day and colleagues in the earlier stage, but nowadays the concept is changed. So anyhow, for the completion sake, I have incorporated this slide. The two-hit hypothesis say, first hit will be the dysregulation of the fatty acid metabolism in either any form of primary risk factor, whatever we want, either diabetic individual or the obesity individual or genetic factor, dyslipidemia, hypothyroidism, polycystic ovarian, whatever it is. If there is a dysregulation in the fatty acid metabolism within the liver due to the particular disease, that steatosis formation is the first hit for the Nafld formation. Then the deposited fat globules going for the different form of the altered signaling pathway, and that lead to the inflammation. Then it causes the inflammation oriented the necrosis. That's why it is taking long duration in the development of the Nafld, leading to NASH and the various stage of fibrosis and cirrhosis and HCC. But nowadays, they mention multiple hit. So the key mechanism in the multiple hit is the liver-gut axis. So this liver-gut axis, not only in the Nafld, in alcoholic liver disease or the hepatitis B, C, all the form of cirrhosis, now it plays a major role, liver-gut axis. So that includes, apart from the first hit, dysregulation of the fatty acid metabolism. That the key factor might be the insulin resistance. Following that, inflammation, not only inflammation, there is oxidative stress, apoptotic changes, fibrosis, regeneration, along with these all aggravated by the liver-gut axis mechanism that will lead to cirrhosis and HCC. So this here I have mentioned the liver-gut, that axis change, that's called dysbiosis. Whenever the liver disease is progress, that time the gut organisms from the gut, because we know the small bowel, everything is drained through the portal venous system that enters with the liver. Liver acts as not only metabolism and acting as a filter for pathogen. Once the liver function reduces, that filtering mechanism will be defective. So that organism entering into the systemic circulation. If you look into that, there will be a rise in all the cytokine markers, particularly IL-6. So the liver disease early stage, there is an increase in the mucosal permeability in the gut mucosa. The bacterial, that time the intestinal, the movement will be slow, the bacterial overgrowth will be there. This all is a vicious cycle, making the more and more inflammation. So not only the dysregulation of the fatty acid mechanism related, This local, slow, ongoing inflammation due to the bacterial PAMPs and the DAMPs, that will cause the vicious cycle wise, the continuous inflammation. So to cut that only, nowadays the drugs are coming out, how to reduce we have to change the gut microbiota, probiotic, prebiotic, giving added advantages in the all kind of the liver diseases. So the liver gut axis plays the key role for the ongoing inflammation. So what are the clinical features? Patient will be asymptomatic. So only if once the patient develops F3, F4 or cirrhosis, then only they develop the features of the chronic liver disease, whatever the way, either the ascites, fatigue will be the most common symptom. And some people might have the right hypochondral, the mild visceral pain due to the hepatomegaly related stretching of the liver capsule, all the thing. So clinical features wise, very difficult to diagnose at the early stage of the Nafld. Here I am giving important this picture, the CVD. So the Nafld or Mafld, it increasing the cardiovascular disease. This comes as a separate paper recently, how the young people are getting more and more cardiac disease. So they retrospectively, when they analyzed it, apart from the routine, the cardiac risk factor, most of them have the associated the fatty liver. So the fatty liver is one of the prognostic factor nowadays coming up, marker for the cardiovascular disease. And the pediatric Nafld, of course, nowadays we are seeing more and more pediatric, particularly about 10 years old children comes with obese, and if you do the ultrasonogram, it shows the fatty liver disease. This mostly due to their diet and the less physical activity. Unfortunately, there is a difference between the adult and the pediatric Nafld. Pediatric Naflds are rapidly progressing to the advanced fibrosis comparing with the adult. Adult, it will take 15 to 20 years to develop the advanced fibrosis. But in pediatric group, it goes to 10 to 15 years, there is more chance. So that's why this kind of the awareness is very important, particularly in the pediatric population. And as already mentioned, the Nafld, now the terminology going to change into Mafld, as it's a metabolic associated, not only liver-related cirrhosis or hepatocellular carcinoma, that increases the cardiovascular disease, obstructive sleep apnea, and associated hypothyroidism, and also worsening the hypothyroidism, polycystic ovarian syndrome. The chronic kidney disease, it is it is not the primary cause, as is associated with the diabetes and other hypertension. So that could be the reason for the associated chronic kidney disease. Surprisingly, not only the liver cancer, it increasing the colorectal malignancies. This has been, papers has been published in separate mechanism, how it's increasing the colorectal malignancy and the vitamin D deficiency. So how to investigate the Nafld? Of course, routine liver function test. Here we can see there will be a rise in SGOT and SGPT, particularly SGPT or ALT. And sometimes a mild alkaline phosphatase level elevated will be there. Sometimes the 25% of the people false positive ANA will be there. And mostly whenever we are evaluating the Nafld, we have to order that fasting blood sugar, HbA1c, lipid profile, thyroid profile, and the ECG, echo, everything, because we have to consider some metabolic syndrome component. Investigation wise, ultrasonogram will easily pick up and it will show bright liver. The radiologist will grade it, F grade stage 1 fatty liver, stage 2, stage 3, but it is totally the observer bias will be there. CT is there's no observer bias. So we can CT and MRI, there need separate the software to assess the fat component. The easy methodology nowadays is the Fibro Scan. And the Fibro Scan is available in most of the cities, and the pharma peoples are helping to use they are giving for Fibro Scan. And all the fatty liver patients, we have to ask them to undergo one-time Fibro Scan. It is a dynamic measurement, and we have to start the therapy, and we have to follow up the case, and we have to redo the Fibro Scan, whether the fibrosis score has been improved or not. So the Fibro Scan is one of the great tools, and the MR elastography is very costly, but it's still available in a very few centers in India. If you look into that advantage, accuracy, I can say. Fibro Scan is very difficult to measure the fibrosis in obese individual, or those who have the already operated, or sometimes they have associated the inflammation. For example, if they have the viral hepatitis, falsely the Fibro Scan will show high fibrosis, but the MR elastography is not like that. The false positive, it will simply I can say accuracy rate is more with the MR elastography. How to interpret the Fibro Scan? We know that machine itself, it will come F1, F2, F3, F4. Nowadays they are giving the scoring card. So the scoring card vary from the etiology wise. So in simple way, we can remember if the kilopascal kPa level more than 12 means we can say F4 or cirrhosis. If it's less than 4, it means no fibrosis. So less than 4, normal, more than 12, cirrhosis. So in between 4 to 12, we can grade it as F1, F2, F3. And at that time we come to the 4 to 6, we can apply 6 to 8, and 8 to 12. The scoring system is helpful to us. Once the patient comes back for our follow-up 3 months later or 6 months later, we can repeat the Fibro Scan, and we can see whether there is a chance of the regression in the fibrosis score. In the cirrhosis, normally is irreversible, but F3, F2, F1, if the patient reduces their weight, it's showing a much improvement. And my suggestion, whenever we are going to do Fibro Scan, we have to do along with the liver function test. So it should correlate with the LFT also, particularly ALT. There are so many non-invasive markers are available, but it is not in practice. It is research oriented. If you look into that, as already mentioned, the interleukin and the CRP level and the apolipoprotein and the cytokeratin and this called metalloproteinase. So many the markers. Whenever this level is high, we can predict the patient's ongoing inflammation in the liver. So it is not a unique to liver, but it is anywhere inflammation goes, it will increase. But ruling out all the other causes, the fatty liver people by doing this one, so it will give an overall clue to us. And the liver biopsy, we are not doing nowadays a liver biopsy to diagnose the fatty liver because very good non-invasive markers are available. But we should know what changes in histology. So as I mentioned, polymorpho, the nuclear, that is the neutrophils, lymphocyte, monocyte infiltration. Where it is getting infiltration, first of all, it will infiltrate in the centrilobular level. So one is we know the portal triad and the central venules. So both the area, but particularly central venule, then portal fibroid. And this inflammation, once it starts to healing, it will cause fibrosis and it go to cirrhosis. So this is the electron microscopic picture of the fatty liver. So this is the sinusoid. S means sinusoid. The right side, it says the hepatocyte, left side also hepatocyte. Whatever the globules, the black color we are seeing is the fat, small fat droplets slightly. But if you look into that, the left picture, sinusoid, this is the very big, that fat globules. So it is distorting the sinusoid. If you look into that, sinusoidal pathways are not clean. So it is bulging into the sinusoidal. We know the sinusoid carries the blood from the portal triad to central. So while carrying the blood, it is giving the nutrient to the adjacent hepatocyte, and it is getting the wasted products, whatever the metabolized, into the system through the fenestrate to the sinusoid. So this sinusoidal flow is getting distorted whenever the hepatocyte is getting swollen up with the accumulated fat globules. It's electron microscope. And the fibrosis score, I said F1 to F4, that is based on the grade. So if you look into that, first in the portal fibrosis and the few septa and the septa are connecting together, and finally it causes the cirrhosis. So the Metavit score. So nowadays the Fibro Scan, where is the histology based, they validated the Fibro Scan or MR elastography. That's why we can predict the fibrosis score in using the non-invasive technique. And there are the other scoring system important. So I wish to tell most commonly used is the Nafld fibrosis score. So here it is if you put the patient's parameter, it's available in the Google. We have to type Nafld fibrosis score, and we have to enter the patient age, their BMI, diabetes, AST-ALT ratio, patient's platelet, albumin. So that will predict F1, F2, F3, F4. So one method is the biopsy. Another methodology is using the Fibro Scan. Even without Fibro Scan, based on the patient's parameter also, we can come to know what stage the patient, F1 or F2, even though they look normal, clinically, we can. There are other scoring systems, are fibro test, these fibrometers are available in market, and the bar score and everything, but it's costly. This nothing, just we have to enter the patient scoring system. That time we can write, okay, you have the F3, strictly follow the instruction, and 3 months or 6 months later, again, we have to check it. If it shows a regression, then we can say you are improving. And the diagnostic algorithm, and I mean that in the next slide I will show that will be better. So how to manage? It is a multidisciplinary approach. So ultimate goal of our treatment, the steatosis or inflammation or ongoing fibrosis, we have to somehow control by giving medication or non-medical method. So the key will be the lifestyle modification. And somehow the patient might require surgical intervention and the pharmacotherapy. So what is the lifestyle modification? Weight reduction. Even though lean diabetic, so that is called the lean Nafld, the patient will not be on obese state, but still they have the fatty liver due to various reasons. Even though that the lean group, the weight loss or the regular walking and the exercise will play a major role. So minimum 5 to 10% weight reduction is the recommended. So we have to send them to the dietitian, and we have to give the instruction to dietitian to give the diet minimum 5 to 10% weight loss in 1 month. That time they will calculate, and we have to see the follow-up. Mostly sometimes the patient will find a difficulty to reach the stage. Some of the patients slowly in 3 months time, they will achieve that stage. and the aerobic exercise. Here I have not mentioned anaerobic. So aerobic exercise means regular walking or swimming or cycling. This kind of the aerobic exercise they have to do regularly. These two things called the lifestyle modification for the correction of the Nafld. Some of the patient might require the surgical technique. Endoscopically also we can do, there is the balloons are available. Endoscopically we can deploy the balloon into the stomach. That will reduce the capacity of the stomach volume. So the patient feel yearly satiety. So that's why we can manage. There is, and at one time we can take out the balloon also. This is the endotherapy technique, but it is not that much successful. Practically, most of the patients, even they'll feel discomfort and they're coming back and telling they are not feeling well after the balloon, the deployment. So another thing, the surgical techniques, the sleeve gastrectomy, these are very popular nowadays, but need the good nutritionist with that, this kind of the bariatric surgery. Otherwise, rapid reduction of the weight loss also will cause liver failure. So they need good surgeon as well as the good dietitian to follow the this kind of the Nafld group. So pharmacotherapy, what are the pharmacotherapy ways we can try? Vitamin E. Vitamin E is antioxidant, we know. So once a day we can give for 3 months. So not more than that. Here, if you look into that, 800 IU. This the vitamin E is working in a non-diabetic Nafld. So not for diabetic Nafld, that we have to remember. If you have a patient with Nafld, obesity, etc., but without diabetic, we can give a vitamin E. It is antioxidant. It is reducing the ongoing inflammation, but maximum 3 months. And if you look, so many the drugs I have mentioned, but that each one has its own plus and minus. But in practice, vitamin E plays a major role. Second one is the obeticholic acid. So obeticholic acid you can use in diabetic individual with the Nafld also. So not like unlike like a vitamin E. So we can use whether the patient is a diabetic or not. In on Nafld, the obeticholic acid we can use, but this obeticholic acid does not give the short-term, the short-term improvement. We have to continue low dose, not a high dose, and a very low dose, 5 milligram OD. That's why we have to give quite long. In case the patient develops the side effect like itching or pruritus, we have to stop the obeticholic acid. And the third is the PPAR alpha and the gamma agonist. And here in India, it's available in a different way. So many drugs are, the cardiology side, we are using the the lipaglutide, and this, the Philips side is coming into that. These all will help for the non-diabetic. That also comes to the non-diabetic, and a few diabetic side also, some of the paper shows it is useful. So the obeticholic acid plays a major role. We should start to use that one. It has so many advantages to control the ongoing Nafld. And there are the current trends. There are the newer scoring system, novel biomarkers, and HEPG ways, target therapy. This all on the pipeline, because whenever the researchers will go more and more, because this Nafld is becoming a epidemic in the non-communicable disease, going as an epidemic. So more and more fund for the researchers to this disease to somehow control apart from lifestyle modification and the whatever available pharmacotherapy, because as we know, it's pathophysiology, whether we can control in a different pathway. So one thing I said, gut-liver axis. So what are the drugs to control the gut-liver axis? Inflammation I mentioned. So how to control the inflammation, and what are the receptors are involving. So anti-inflammatory and anti-fibrotic methods and the metabolics. So many newer drugs are in pipeline. In future, we will get it. And this is the way the Nafld is progressing. And ladies and gentlemen, so the take-home message. So Nafld is one of the, now it's called the Nafld metabolic associated. So we can easily prevent the disease if you know the risk factors, and we have to take steps to correct the risk factors, lifestyle modification or medication, etc. And clinically, I mean, it will not cause any symptoms. We have to closely monitor. We have to do the scoring system to assess. And if the patient has symptoms, and we have to follow it up, whether they're regressing or not, or the patient going for the cirrhosis, or we have to do the tumor markers screening also for most of the F3, F4 fibrosis stage. Alpha fetoprotein, FIFCA2, even once in a year we should do. That time we can diagnose, or the good imaging, CT scan, we have to do once in 3 years or once in 5 years. That will pick up the early HCC. And even after transplant also, due to the immunosuppressive drug, we are seeing most of the patients with the Nafld. And the pediatric Nafld is a really worrying things, and it need address. So this is the flow chart. If the patient comes with ultrasonogram, if status is there, we have to look into that ALT. If it is normal, fine, follow it up. And meanwhile, we have to look into that other associated reason for fatty liver and the risk factor for fatty liver, we have to take a correct step. If there is enzymes are increased, the patient need lifestyle modification, pharmacotherapy, and correcting the risk factors, everything. Okay. This, I mean, I have to thank to all my, on behalf of my team peoples, to all the APA members in the Trichy chapter, and all who are seeing that our webinar. Thank you. Thank you so much for giving opportunity to me.
Thank you, sir. Thank you, sir. That was a very wonderful lecture, sir, starting from the risk factor, and you covered up to the recent trends and the newer targets. And we'll have the discussion after the second topic, sir. We'll finish the second topic also. And I request Dr. Saravanan, sir, for this second topic.
My slides are visible, sir.
Yes, sir. Visible, sir. Since Sir is continuing his previous talk, I don't put his introduction slides and all, because everyone knows about Sir, and everyone is waiting for Sir's talk.
I really thank you, Dr. Muttumani and Shivashankaran, sir, for considering me to continue with this part of my presentation, which I did a month ago. The topic is on complete blood count, the count that counts. I was discussing about RBC component of the complete blood count. Especially I was touching upon, just recap what I've done. So it's easy for every one of us to go ahead with my flow of presentation for this meeting. So what I've done is I was discussing about red blood cell counts, especially related to the basics, and followed by iron deficiency, immune hemolysis, as well as macrocytic anemia. So what I'm going to do in this current presentation as a continuity, I'm going to discuss about the common issues which we come across in the clinical practice, especially thrombocytes related issues. And further adding upon to the previous presentation, I'm going to touch upon few aspects of red blood cell related issues, leukocyte abnormalities, and trilineage problems, as well as ESR abnormalities. If time permits, my interesting area of eosinophil abnormalities as well. I'm going to take you all through, as usual, the previous presentation. I'm going to take you all through the case witness. It's a 30-year-old female admitted with cortical vein, known case of cortical vein thrombosis, admitted with right side pleuritic chest pain, right leg pain, and she's been diagnosed with right side pulmonary thrombosis and deep vein thrombosis. So this is a very common scenario, probably everybody would have come across. And the investigation of this patient, is blood cell count, hemoglobin slightly lower side, MCV is a normocytic, and total count also nearly normal. But if you see carefully, the platelets on the lower side and MPV, PDW is acceptable. So basically the scenario is basically dealing with a person who's got tendency for thrombotic episodes of multiple sides of young lady with a low platelet. I think everybody would have guessed what I'm trying to reach at. It's a basically thrombocytopenia with thrombotic tendency, individuals, female gender, young lady. Probably we are dealing with APLA or antiphospholipid antibody syndrome, maybe a primary or secondary APLA. It is not only the scenario which we come across with the low platelets, but also we do come across different types of presentation of the low platelet, that is thrombocytopenia, maybe in the form of asymptomatic or symptomatic low platelet. And even this can be coexisting with white cell defects, maybe low or normal. It's bicytopenia, and maybe associated with short febrile illness with low platelets. So what I'm trying to highlight here is the different scenarios which we come across commonly in our clinical practice related to thrombocytopenia. The other important scenario which we come across is the clinical entity called immune thrombocytopenic purpura, ITP. Most of the time it's incidental or symptomatic in the form of the purpuric spots. So naturally, when you see a patient with low platelets, these three questions should strike your mind before proceeding with investigations. First one, we should ask ourselves, is the thrombocytopenia real one or real one? And is it a new one or an old one? And are there other hematological abnormalities? Probably if you recollect, I was mentioning about a scenario where you can get coexisting conditions of low platelet with white cell abnormalities, or I'm going to show a few other examples where this can be coexisting situation. So it's very important to find out answers for this. Always very meticulous history taking is important. Go through the previous episodes of any related events related to this low platelet or drug history, or even can ask for the previous timing the patient has undergone the investigations to compare with. It may be a year or two or even months. It is very important for us to interpret the current value of low platelet. Always should be relation with the previous episodes or previous reports. It is not only that, when you're interpreting a low platelet or analyzing a low platelet, it is very important for us to understand the quality of the lab. Certain technical reasons the patient might come to you with low platelet report, which may not be. So it's very important aspect before interpreting the report. It's very holistic approach of this low platelet to be done. So what is low platelet? As we all know that the normal count is 1.5 to 4.5, whereas if it's going to be less than 1.5, it is said to be the low platelet or thrombocytopenia, which can be graded in the form of mild, moderate, or severe. And there is different the guidelines or different associations giving such difference in the numbers, but orbitally you can keep mild as 1 to 1.5 per microliters, whereas moderate is 50,000 to 99,000, and severe is said to be less than 50,000. It's very important. Certain normal variations of the low platelet we should always remember before interpreting the report. So basically the mean values of this platelet can be between 2.66 to 2.37. That is 2.66 seen with the female gender and 2.37 with the male gender. And the count slightly higher in women than men, as I mentioned, and slightly higher in younger people than the older people. And the counts are higher in non-Hispanic blacks compared with white individuals. It is not only that, the day-to-day variations, and even within the day, morning to evening, there can be difference of 20 to 30,000 cells. The evening is lesser because of mechanical trauma the patient or person is undergoing. So there are so many differences in the values of this. Basically, it's a bit of a dynamic numbers. It's always a bit familiar with. Is easy for you to interpret the low platelet count. And when to say significant fall in the platelet count? is it the individual number of, as I mentioned, the mild, moderate, severe, or even the count is coming down from, for example, the patient's count is usually 400,000. It is coming down to 200,000. That is more than 50%, even though it's well within the normal range. It's always said to be abnormal count values that needs to be assessed and analyzed and act according to the scenario, which leads to drop in the count of 400,000 to 200,000. And when to worry about bleeding, I was mentioning about ITP, immune thrombocytopenic purpura, as a last point, because among the low platelet counts conditions, the ITP is one of the common condition which we come across other than the infections and drug-induced problem. So the common scenarios which we come across, of which the low platelet producing symptomatic, that is in the form of bleeding tendency, it is not so common with pure isolated ITP compared to other coexisting conditions, especially hematological malignancies. And it is not only that, the platelet functional defects, it is not only that, the coexisting coagulation factor defects. So the three scenarios where the clinical symptomatic presentation of the low platelet, especially in the form of major bleeding tendency, is common compared to pure isolated ITP alone. So it's very important. The concept of safe platelet count is imprecise and lacks evidence-based recommendations and depends on the disorder and on the patient. Even with the same disorder, the patient's behavior can be varying. So it's very important. So what I'm trying to highlight, or what I'm trying to put it across to you all, is basically I want to say, don't jump into the platelet transfusion based on the number alone. Please don't transfuse platelet transfusion without a proper understanding of the disease. That's very important. Don't postpone the major or important investigations, even going to be of invasive procedures. Kindly understand the disease process and try to proceed with invasive procedures, even including your bone marrow examination. Suppose, for example, a scenario where the patient is requiring an aspiration of the therapeutic aspiration of the pleural or the ascites, can be carried out in a very, very meticulous manner without much trauma. You can very well safely relieve the patient's symptoms even with the low platelet count. This point, if you are able to, if we are able to reach you all, I think my purpose is served. And it's very important, the theoretical points all of you might have been familiar with. The surgical bleeding is commonly seen with less than 80,000, or you can say even 50,000. But the major procedures like the neurosurgical procedures or the cardiac surgical procedures or major orthopedic procedures can be carried out. The count is above 80,000. It's a very important point. And it's not only that, even the low counts like 30,000, 20,000, just now I was trying to tell you people, is safe to perform the conditions or procedures like dermatological procedures, cataract surgery, and bone marrow aspiration and biopsy. And theoretically, yes, spontaneous severe bleeding is possible with less than 20,000 or less than 10,000. As I was mentioning, few aspects of these clinical scenarios to be kept in mind before thinking about or before anticipating the spontaneous bleeding, especially in cases of the person is having platelet functional defect or having coagulation defect or having the reason for the low platelet is going to be hematological malignancy. The spontaneous bleeding is very common. So once again, reinforcing on the statement, the pure ITP alone having a spontaneous bleeding is a bit unlikely. And this is what I was trying to highlight. These other factors also to be kept in mind. And the scenario which I was trying to highlight in the beginning of my presentation, even though I was talking to you about last 5 or 6 slides about the bleeding tendency, as we all know that the low platelet is always common to have a bleeding tendency, but it's also can have the clinical presentation in the form of thrombosis. This is what I was highlighting in my case scenario. So these are the few conditions which can lead on to low platelet at the same time thrombotic episodes. The first and foremost, we should always think about APLA. Number 2 is Parent-Induced Thrombositopenia. Now we started using after this COVID vaccination, the vaccine-induced ITP, that is WIT, and disseminated intravascular coagulation. It always starts with the thrombotic episode followed by bleeding tendency, and TMAs, thrombotic microangiopathies of TTP or HUS, then paroxysmal nocturnal hemoglobinuria. It's very also important to think about, is it a problem of two disorders in the form of ITP with the concomitant thrombotic disorders? So when you see a patient with low platelet, it is not necessarily to have a bleeding tendency, but also to have thrombotic episodes. Always think about these scenarios when you start seeing the patient with thrombotic episodes. So what are the thrombocytopenic emergencies requiring immediate action? Probably the number alone is not the criteria to think about planning for transfusion. It is also very important, the tendency for bleeding, or having come across a patient with a bleeding tendency, or a patient come to you with the thrombotic episodes, whatever is highlighted here, just now I mentioned, and suspecting coexisting conditions like leukemia or aplastic anemia, the chances of bleeding tendency is going to be more and more than isolated low platelet because of, maybe I would say, like viral infections, drug induced, even ITP. So what are the helpful aspects in the history taking of the patient with a low platelet? Probably it's very important, always ask for prior platelet counts, family history of bleeding disorders or family history of thrombocytopenia, history of bleeding, medications history is very important, infectious exposures, dietary practices, maybe a part of your B12 deficiency, other medical conditions like hematological disorders, rheumatological disease, or even bariatric surgery, blood product transfusion can trigger the immune mechanism that can lead on to a secondary low counts because of immune-mediated organ transplantation patients. So it's very important, the clinical conditions of more concern with low platelet. Once again, probably I would say it's all reinforcing on the same information which I'm trying to highlight is associated with the fever conditions, which is mentioned here, hepatosplenomegaly. The patient can be associated with the neurological findings, lymphadenopathy, even the patient can have thrombotic episodes. So always when you see a patient with the low platelet, if postgraduates are involved in this academic program, I would tell them to go for all these points to be kept in mind when you see a patient with low platelet. Don't coin the patient as ITP. So I was talking about errors in the sample collection. Before interpreting, the laboratory quality is very important. It is not only that you might come across pseudothrombocytopenia, maybe EDTA bottle related, that is purple capped, the vacuum container. Maybe you can go for even the heparin or citrate base, that is green or blue color capped. The containers will tell you a better way of interpreting. You can also ask for manual count to make it more clear to you. Unless the patient is very seriously ill with a low platelet of highly symptomatic, can intervene. Otherwise, just wait, ask for these alternative methods to find out what exactly the true figure of platelet count. So this is the normal picture of the peripheral smear, which is showing the biconcave, the RBCs, but you can also see the platelet counts, platelets. This is basically the clumped platelets. It's basically clumped platelets. The Coulter machine, what it does is, it's the size of the clumped platelets will be around the 6 to 7 micron, which is equivalent to low lymphocytes or small lymphocytes. So the Coulter counter starts counting these cells as micro lymphocytes or small lymphocytes. So you'll be getting a falsely low values. It's very important. The reagent used, the technique used, the quality of the lab, all these things are very important to interpret a report. I think with this, I'll finish the low platelet. I hope I conveyed one or two important points. Before jumping into transfusion of the blood products, always ask for repeat count, manual count, check the quality, previous values, complete historical aspect, examine the patient, anticipate any tendency for bleeding, then take a decision whether to intervene or not. Low platelet alone is not contraindication for important procedures. Probably based on the numbers, you take a decision and go ahead with the important essential procedures. Now I'm moving on to raised counts. So what I was discussing is low counts. What I'm going to discuss now is raised counts. I'm going to show one or two scenarios. It's a very common scenario which you come across with these elevated platelets, that is thrombocytosis. Elderly people, 6 months duration of burning feet and hands and disturbed sleep and neurology consultation multiple times done, and the evaluation of 6 months duration. At least you would have seen 3-4 neurologists, and they each and every time they started doing investigations. And what are the scenarios? By the way, I'm projecting here all our own unit case scenarios. I'm just sharing one or two scenarios, and it's all real case scenarios which I'm trying to highlight here. It's not created one. And the neurology consultations and patients coming to us with once again the same symptom, and I could get at least 4 or 5 investigations papers of 6 months duration, which was going through that and going through the all neurological investigations also, which I could pick up the patients, the counts wise, blood count, very basic blood counts report, which is striking to me with RBC slightly lower side. Total count is acceptable or low normal, I would say. Platelet count is very high values. I was mentioning about 150,000 to 450,000, but this patient's platelet count is 998,000. But when I was going through that serial of investigations, the patient has undergone last 6 months or so. This count started with the 6 months back. The first investigation, which is showing around 600,000, now is gone to 998,000. So as I was mentioning, the low platelet always rely on the or depend on the previous investigation chart. We also here also same. So it's basically it's a dictum for any blood count report. Always ask for the previous report. If you are getting this point, I think I've done a big job to you people. What basics are required for this the interpretation of the complete blood count as it is. And this patient is definitely having an elevated count. There is no doubt about it. And another scenario, this patient is symptomatic high platelet count, whereas the other scenario is very common. 60 years old male, as forced by their children, he has undergone the routine evaluation as a muscle checkup, which is picked up the elevated platelet count. That is asymptomatic elevated counts. So if you see carefully, there are two scenarios. One is highly symptomatic elevated counts of platelet. Other one is asymptomatic. This patient is a pre-operative. Another patient is muscle checkup. They picked up the elevated counts. So this is basically a erythromelalgia, or what is called as the symptom which I was trying to highlight in the scenario of the first scenario. It is basically the condition is associated with burning pain in the feet or hands accompanied by erythema, pallor, or cyanosis in the presence of palpable pulses, and is common in both. It's very important, essential thrombocytemia and polycythemia vera also. That's the reason I just this patient's count is only within normal limits, slightly low hemoglobin. The other extreme also can have because of polycythemia rubra vera. And basically the thrombocytemia, the criteria, platelet count is very important, and bone marrow biopsy should be showing about the abnormal megakaryocytic population, should be hyperlobulated nuclei. And the other conditions which is not meeting for to make an impression of essential thrombocythemia should not meet the WHO criteria for BCL, PCR, ABL, or CML, or PV, or the PMF conditions, or myelodysplastic syndromes, or other myeloid neoplasms. And you can get positive similar to your the CML or polycythemia. You can get presence of JAK2, or specifically for low high platelet can come across CALR or MPL mutations can be positive. And the minor criterion is the clonal marker, presence of the clonal marker, absence of evidence for reactive thrombocytosis. Basically, you should understand any patient with thrombocytosis, first always think about reactive thrombocytosis. Try to look for causes of reactive thrombocytosis, that it has to be ruled out as a minor criteria to make an impression of essential thrombocythemia. So the patient should have meeting all 4 major criteria, or the first 3 major criteria, and the minor criteria to say that we are dealing with essential thrombocythemia. So it's very, very important. A common scenario which we come across in our day-to-day clinical practice. It may be an incidental finding, it may be a symptomatic, but it's very important to think about a reactive thrombocytosis to be ruled out before coining this patient based on the WHO criteria to say it's a essential thrombocythemia with the 4 major and 1 minor criteria. These are the many causes of reactive thrombocytosis. I'm not going through this. Probably you can all go through that. Is available in the standard resources, and just go through that. First and foremost is simple anemia of iron deficiency can have reactive thrombocytosis. The natural question comes, as far as the number is concerned, the platelet count, how much rise you can expect for reactive thrombocytosis. So there is no definite numbers, but even then, the count can go from 450,000 to even can go to 900,000 or 1,000 can be there. But having come across a patient with above 800,000 or 900,000 or 1,000, it's always very important for you to evaluate for essential thrombocythemia. That is very important take-home message, I would say. With the elevated platelet count, there is no definite numbers to say it's reactive, but even then it's the most common cause. But always keep in mind, when the number is going beyond 800,000, start thinking about, start planning for, evaluate for essential thrombocythemia. So the urgency of evaluation, this is what I was trying to highlight here. Count is going to be above 800 or even 1,000 is going to be a real number for you to think, plan, evaluate for essential thrombocythemia. This is the flow chart which is given your standard references. Probably everybody can go through that. I'm not going to read out this chart, but first and foremost is look for reactive, then numbers wise plan for essential thrombocythemia. This is the normal peripheral smear showing the red blood cells as well as the white cells as well as platelets. But this is basically a patient with essential thrombocythemia, multiple clumps of the platelets and more number of large platelets is all very classical characteristics of the peripheral smear in a patient with essential thrombocythemia. It's very important. Probably you can discuss with the liaise with the pathologist to get a better idea about how the platelets looks like under the microscope. And there are certain points which can get as a clue, but it is not always. Sometimes similar to the MCV, mean corpuscular volume, and the RDW, red cell distribution width. Sometimes you can get with the MPV and including your PDW, platelet distribution width, but it is not always. And definitely the MPV is more than 11 femtoliters, considered to be the mega size of the thrombocytes, and it may be immature cells of the platelets, which also to be thought about as a myeloproliferative disorder or even the familial platelet disorders. And anemia, as I was mentioning about, especially microcytic, can have reactive thrombocytosis. There is no numbers, but even then you can keep a target value of above 800,000 as a target to evaluate for other conditions. Already mentioned. Yeah, the history wise very important. Already mentioned about it in the flow chart, or I was just trying to highlight here the bleeding, medications, and the chronic hematological disorders, unexplained fever. Physical examination wise, always try to look for evidence of the bleeding tendency, bit of contrasting one, because you are dealing with the elevated counts, but bleeding also equally common compared to thrombotic episodes of raised platelet count. That's very important. Lymphadenopathy, hepatosplenomegaly, and any evidence of thrombosis, very important. So common to the raised platelet count, both bleeding as well as thrombotic episodes. So with this, I finished my elevated or raised thrombocytes. I conveyed one or two important aspects of the thrombocytes related. Now I'm moving on to the other aspect of the red blood cell, which I dealt in the previous presentation, is more of a drop in the hemoglobin, microcytic hypochromic anemia, macrocytic anemia, as well as immune-mediated and hemoglobinopathies, which now I'm going to discuss about a patient with a 70 years old female, burning sensation of both lower limbs for 6 months, evaluated for the same, similar to the patient with essential thrombocythemia, where the RBC count is 6.5 million, white cells elevated, platelet count is upper normal, ESR is lower side, 2 millimeters per hour. If you read this report, probably everybody would have got some clue that the scenario which I'm trying to highlight is having what is called as it's a pan-myelosis. So all the 3 types of cellular lineage or trilineage rise in the counts of RBC, white cells, as well as the platelets. This is the picture of the peripheral smear of this patient, which is showing multiple rise in the number of RBCs, but not only that, you also got rouleau formation. So basically, the problem which we are dealing is polycythemia rubra vera. I hope I'm not crossing the time limit. Muthamani sir, kindly stop me if I'm crossing the limit of my time.
Okay, sir. No, sir, you can continue, sir. We have time, sir.
And the criteria was WHO criteria. It's all taken from the standard references. The hemoglobin is very important, but very important is always you get guided by the level of raised hemoglobin by your hematocrit. So hematocrit more than 49% in men or 48% in women is very important. We don't go for increased red cell mass as a calculative values. We don't do that in our daily practice. Second one is bone marrow examination showing the trilineage changes and presence of JAK2 V612 617F mutation, or if it's going to be negative, better to go for JAK2 exon 12 mutation. Minor criterion is always subject the patient for the erythropoietin level. You should demonstrate subnormal serum erythropoietin level. So when you see a patient with the elevated RBC count, always look at immediately on the hematocrit what exactly the value. The value is above 50, 55, 60. That will give you a guide. I was mentioning about it goes to give you a guide. Guide in the sense you can plan for therapeutic venous section, which is basically targeting at to bring down the number is around of hematocrit 50%. It is not the red blood cell number or it is not the hemoglobin. You are completely guided practically in a clinical scenario for whether you achieve the satisfactory number of the drop in the RBC count basically by hematocrit, and you can go for therapeutic venous section. And these are the causes of reactive, similar to the raised elevated, so raised counts of platelet can also get the relative polycythemia or absolute polycythemia, which is basically dividing into primary polycythemia or acquired polycythemia of somatic mutations or some other triggers, which will have elevated erythropoietin level. So basically, if you divide that into first one, you are demonstrating RBC count, hemoglobin, hematocrit. All the 3 are elevated, not necessarily white cells as well as platelets, in which case immediately ask for history of high altitude, history of smoking, history suggestive of any features of hypoxemic episodes of the individual continuous constant process. So you check for the SpO2 of the individual. Even you can go for blood gas analysis, then followed by ask for the EPO level with the peripheral smear and ESR, which will tell you clear idea about are we dealing with normal erythropoietin, low erythropoietin, elevated erythropoietin. So hypoxemia, elevated erythropoietin, it is understood hypoxemia was the stimulation for factor for the erythropoietin, which makes the RBC count to go up. So it's very important, a basic bedside, our day-to-day practice. If you are keeping these few parameters in mind, you'll be able to simply evaluate a patient with elevated RBC count. So this is what I was trying to highlight here. It's very important you go with the hematocrit values of more than 49 in men or 48 in female. And other conditions to be kept in mind. Probably everybody can go through this, the standard references available up to date, and EPO level peripheral blood screening for JAK2 617F mutation or JAK2 exon complete workup of your patient with erythrocytosis. So the clinical and laboratory features of polycythemia: persistent leukocytosis, thrombocytosis, microcytosis due to iron deficiency. It's very important. It's a very practically, if you see, it is not necessarily the patient should have a normocytic, normochromic. Patient can have because of trauma, mechanical trauma on the RBCs because of clumped cells passing through or jam-packed the blood cells passing through the blood vessels, which can undergo trauma and can produce microcytosis due to iron deficiency, splenomegaly, and generalized pruritus, especially post-bath, and unusual thrombosis and erythromelalgia, that is acral dysesthesia and erythema, which I was highlighting in the previous pictures. So once again, the point is about the polycythemia, relative polycythemia without an increase in the RBC mass, but absolute polycythemia basically with increase of the RBC mass. And also try to look for, which is basically reflecting the primary polycythemia, RBC mass is more, whereas secondary polycythemia where there is increase of RBC caused by elevated serum erythropoietin level. So that's all about the polycythemia rubra vera. So the point which I was trying to highlight is basically looking at the hematocrit, historical aspect, always try to look for coexisting iron deficiency, better to be guided by your the hematocrit value for therapeutic venous section, the primary therapy for polycythemia rubra vera. Moving on to the next, the cellular problem which we come across commonly is leukocytosis. The scenario which I'm going to discuss here is 52 years old male from OT, history of unwellness and abdominal fullness, history of early satiety, history of mild weight loss, non-alcoholic and non-smoker, per abdomen, massive splenomegaly. Probably all of you would have guessed which the scenario which I'm discussing about with the leukocytosis, the basic heading. All of you would have guessed that we are dealing with problem. I'm trying to highlight the counts here. The white hemoglobin is 11.1, platelet is normal. Even you can get this type of scenarios, elevated platelet count, and the WBC is 84.2, and the blast and the other the subtypes of the WBC is mentioned here. But when you see carefully, the band form is more. The two conditions where you will get band form more is macrocytic anemia of B12 deficiency, as well as this scenario. And the basophils also higher side. One of the common reasons in a common practice is this scenario where you will be getting basophils and to some extent eosinophil count as well. So scenario which we are discussing about is elevated white cells of neutrophilic. It's a more of chronic myeloid leukemia. So it can present as extreme thrombocytosis, even though the scenario which I was projecting here is carrying the normal platelet count. It's a commonly asked MCQ also. The thrombocytosis, other than your essential thrombocythemia, polycythemia rubra vera, the chronic myeloid leukemia, all these three category of problem, all the three diseases coming under category of myeloproliferative disorder. And it's a close differential diagnosis. Just now mentioned about is essential thrombocytosis. Maybe only peripheral blood finding in the chronic phase of CML. As we all know that the CML can be in the form of chronic phase, accelerated phase, or acute flare phase. And BCR ABL to be looked for, and all patient thrombocythemia should be investigated for BCR ABL translocation. This is a very important point from the practice point of view. All the postgraduates should remember this. The patients with thrombocythemia should be subjected for after proper flow of information which you're trying to understand the problem of the patient. One stage you are supposed to request for definitely BCR ABL to make it what clearly the problem you are dealing with. So that's all about the thrombocytosis. Even though I said 1 or 2 points, but very important. Other conditions where you will get leukocytosis, the commonly infections and inflammatory conditions where you can get even myocardial infarction, you can get elevated white cells. Only point which I want to highlight here is don't jump into antibiotic therapy based on elevated counts. If you don't do that, you are doing a good job to the patient. So the other scenario, till now, we have been discussing about elevated platelet count, elevated RBCs, elevated white cell count. What I'm going to discuss now is the trilineage problem where we are dealing with pancytopenia. So when you see a blood count as it is, we are supposed to look at first RBC component, then immediately look for WBC component, also to look for platelet component. The patient which I'm going to deal now is pancytopenia. So this patient, basically a 44-year-old male presenting with fever, abdominal pain, fatigability. His laboratory results as follows: the white cells lower side, hemoglobin lower side, platelets lower side, and elevated AST, ALT, alkaline phosphatase, and bilirubin also elevated. Bilirubin also elevated. Fibrinogen is lower side, ferritin is grossly elevated. So this picture, I don't know how many of you are able to pick up the disease which we are dealing with. A patient with the pancytopenia, elevated enzymes of the liver, and bilirubin is elevated, drop in the fibrinogen, and ferritin is sky high. So this problem, this is what I mentioned here, and there is no abnormal type of cells seen with this peripheral smear. Bone marrow biopsy I'm going to show. We'll see how many of you are able to pick up. This is the bone marrow examination of this patient. There are two pictures, figure 1 and figure 2. Basically, it is looking at the engulfment of RBCs as well as engulfment of white cells also seen in this picture. The first one is engulfment of RBC. Second one is showing engulfment of WBC. Probably many of you would have guessed what I am trying to highlight now. The bone marrow showing some sort of one cell is engulfing other cell, and the peripheral smear showing pancytopenia. Second one is low fibrinogen, sky high ferritin level, and these are the differential diagnoses you can keep in this scenario: aplastic anemia, acute promyelocytic leukemia, myelofibrosis, hemophagocytic lymphohistiocytosis or macrophage activation syndrome, myelodysplastic syndrome. These are the 5 scenarios. Always keep in mind when you're dealing with this scenario. And the answer for our patient is, it's basically HLH or macrophage activation syndrome. Basically, the pancytopenia, all the 3 cells are lower side, and the scenario which we dealt is basically HLH, which is basically fulfills at least 5 of the main diagnostic criteria for HLS, like it is, that is the fever, splenomegaly, cytopenia, elevated ferritin, low fibrinogen, and evidence of hemophagocytosis of the bone marrow. So basically, HLS can have peripheral smear also showing the hemophagocytosis, or most of the time we pick up this problem from the bone marrow examination. Probably the primary HLH 2004 protocol as well as revised protocol can be used to manage this patient, starting from investigation as well as therapeutic point of view. But what are the mechanisms of pancytopenia? So when you see a patient with pancytopenia, don't get panicky. Always think about the 2 important mechanisms, or I would say like 3 important mechanisms. First one is, are we dealing with, as we all know that the production unit is going to be bone marrow, are we dealing with bone marrow infiltration or replacement? Or is really a bone marrow has gone in for aplasia, that is poor defective capacity to produce, not because of infiltration, because of completely destroyed? Or is it because of peripheral blood cell destruction? Pancytopenia, always think about, am I dealing with bone marrow problem or am I dealing with the peripheral blood problem? So this emergency is associated with pancytopenia. It can be any form. It can be, depends on the severity of the low counts, whether it's RBC component, white cell component, or platelet. It is not only that, the quality of cells. When there is a bone marrow infiltrations, replacement, or aplasia, it is not only the number is reduced, but also the quality of cells is reduced. So naturally, it depends on the quality of cells, which we cannot clearly made out from the peripheral examination or from the historical aspect. The patient come to you with white cell related problem, or it can be in the form of symptomatic anemia, or can be in the form of thrombocytopenia, or can be bicellular problem, even that can come to you with pancellular problem. It's very important to think about the clinical presentation also, but bottom line here is pancytopenia always subject the patient, even I would say bicytopenia, subject the patient based on the scenario, bone marrow examination. Isolated low hemoglobin, isolated platelet count alone may not be getting extra information to the bone marrow, but bicytopenia or pancytopenia definitely will be getting extra information by subjecting the patient by undergoing the bone marrow examination. This is the different causes of pancytopenia based on the mechanism, which is also taken from the standard reference. All of you can go through that. I'm not going to go through that. The physical findings wise related to individual cellular component, try to address. That is, in the form of rashes or oral lesions, can be in the form of lymphadenopathy or splenomegaly or jaundice or stigmata of liver disease. Very important, because when you are going to deal with the pancytopenia, equally give importance for 50% for peripheral mechanism versus bone marrow mechanism. So most of the time we forget about peripheral mechanism, always think about peripheral mechanism, that is splenic sequestration of the cells leading on to pancytopenia or bicytopenia. So the investigation, which includes definitely blood count, peripheral smear is very important. Retic count to make you to understand the need or the reservoir capacity of the bone marrow, and complete metabolic panel is very important, especially calcium values and LDH values and PT, APTT values and blood type and strain. So that's all about the pancytopenia. So the pancytopenia, when you see a patient, always think about two mechanisms. Always ask for peripheral smear, understand the capacity of the bone marrow reservoir in the form of retic count, followed by metabolic panel of investigations. Equally give importance for peripheral mechanism, subject the patient for ultrasound, looking for spleen, evidence of peripheral splenic sequestration, and clinically look for evidence of splenomegaly, lymphadenopathy, all the three cell lineage related symptomatic problem, maybe in the form of infarction, symptomatic anemia, or symptomatic platelet abnormalities. Okay, so this patient, moving on to the next topic on ESR, specifically Muthamani sir asked me to cover up this part also. So I'm going to cover up this part. I hope some more time is there, sir. 10 more minutes, 15 minutes. Can I take, sir?
Yes, sir. Yes, sir. You can take, sir.
Okay. So this scenario, this I would say this patient which I came across 18 years back, that is 2004 or 3, I came across this patient. 70 years old male, history of unwellness, loss of appetite, 1 year, admitted with fever, respiratory distress of 3 days. And the patient had low hemoglobin, grossly 125 is his ESR per hour, and mild renal impairment, raised calcium, urine abnormalities, chest X-ray was showing parenchymal infiltrations. So by this time, everybody would have guessed what I am talking about. Under the topic of ESR, I'm talking about the scenario. Probably everybody would have guessed what a scenario is talking about. This patient, what I dealt is basically multiple myeloma. It's basically a protein abnormalities, which is dealing with the problem of raised ESR, one of the commonest condition which we come across. Basically, ESR is a non-specific test for inflammation, easy to perform, widely available, inexpensive, widely used screening test, yes, agree, monitoring tool for response to treatment. But having said all these points, the problem with this ESR assay is so many technical reasons which can lead on to elevated ESR. So similar to the peripheral smear examination, similar to the platelet count I was trying to highlight, do from a standard lab. Similarly, ESR should be done from a standard lab, not from small centers where they are not very well equipped with to carry out this ESR. Even as a basic is commonly done investigation, the technique can change the value, will make you to interpret in a different sense. Okay, so what are the factors which is basically contributing for erythrocyte sedimentation rate. Basically, it carries its own meaning of erythrocytes playing a major role in deciding upon or determining the ESR, plasma composition, especially protein component, even the mechanical and technical factors also playing the value of ESR. The erythrocytes wise, few factors which I'm going to highlight. Macrocytes tend to sediment rapidly than microcytes. Alterations of ratio of red cells to plasma will have effect on the ESR value. Decreased red cell mass in anemia increases ESR. Very practical tip, in a patient with anemia, even this scenario which I'm trying to highlight, you can take that as an example. If there's a drop in the hemoglobin of 1 gram, roughly we expect a rise of ESR of 10 millimeters per hour. If the patient's ESR done from a very qualified, well-validated laboratory, the ESR for the hemoglobin is above this cutoff comparison. 1 gram drop is going to raise your ESR by 10 millimeters per hour. If it's going to be beyond that, think about, are we dealing with, it is not directly related to low hemoglobin, are we dealing with any other problem of this patient to make the ESR to go up? It's very important basic practical tip. And the scenario which I was trying to highlight in the polycythemia, I was showing specifically about the ESR is very low. Red cell mass increase can produce decrease in the ESR. It's very important. Sickle cells and spherocytes are unable to form the rouleau and ESR is always lower side. So the few factors which will influence the ESR value. So that's the reason it's a commonly done, but interpret based on the available other investigations and scenario. Plasma composition. Basically, if you see RBCs, each cell is having the negatively charged potential that is called a zeta potential, which makes to repel each other. But when you have a plasma abnormal protein, basically the fibrinogen, immunoglobulins, or acute phase proteins like C-reactive protein, ceruloplasmin, alpha-1 globulin, which will reduce this negative charge, which will make this rouleau formation to happen. This is very basic physiology which you learned during your first year MBBS. It's worthy to do, keep in mind while practicing this and interpret the report. Removal of the fibrinogen by defibrillation, increase in the albumin can retard ESR values. It is the contribution by the plasma composition. The other mechanical and technical factors, it's very important. That's the reason I said lab is very important. The ESR tube to be exactly perpendicular. Even the tilt of 30 degrees can cause errors up to 30%. The rack holding the tube should not be subject to any movement or vibration. If you remember, you would have done our the physiology lab when we did our first year MBBS. You all kept the ESR tube separately in the rack and just stay away from that. Wait for the ESR values to be measured. When we do other activities in a different place, not at the same place. And the sedimentation rate increases as the temperature increases, and ESR tubes with a narrower than the standard bore will generally yield lower sedimentation rates. So that's the reason I made a statement. Well qualified, validated lab will give you an exact value of ESR. That is because of it will not have much of the mechanical or technical factors going to influence the outcome of ESR measurement. So there's a few causes of elevated ESR, even though it's a non-specific, it's worthy to note. Inflammatory, infective conditions, all the very important conditions which we come across with elevated ESR. But keep in mind, the decreased ESR also carries the important, very few conditions where you should remember about the erythrocytes, plasma composition, or is it because of the technical reason? The conditions like polycythemia, where red cells are elevated, hypofibrinogenemia, congestive heart failure, even the other conditions like the abnormal hemoglobin factors, especially sickle cell or spherocytes, can have drop in the ESR. So ESR basically it's a non-specific. Always keep in mind three factors: RBC, technical factors, plasma composition to interpret the report of ESR values. And the sources of errors in ESR assessment: improper ratio of blood and anticoagulant, hemolyzed sample, clotted blood, presence of air bubbles, errors due to sunlight, vibration, small bore size, dirty, wet tube, or even delaying the performing of the test. There's so many ways to get the influence of the other factors on the ESR value of the individual. It's very important. Transport the specimen, make the pathologist or the technician to carry out the perform this testing immediately, so that you'll get a better in a qualified, well validated laboratory. The exact figure of ESR will be able to get it. I think with this come to a conclusion, but I have one more presentation, very short presentation, eosinophilia. Shall I proceed, sir? Only on eosinophilia, maybe 4 or 5 slides I have. I don't know, time permits, or shall we wind up, sir?
Yes, sir, we can proceed, sir. We have 10 more, 5 to 10 minutes. We can take.
10 minutes. I'll just finish off. It's only 5 or 6 slides more. So this basically my interest area in hematology. I'm more interested in hematology. My interest areas are all fields of any red blood cell, white blood, as well as the platelets. And I'm more into, we are collecting a series of eosinophil related problems, and we are going to publish that also. The 25 years old female, history of increased bowel movements for 3 months, no weight loss and no abdominal pain. And normal blood counts with the ESR. Further investigations, the patient underwent as evaluation of the diarrhea, increased bowel movements. Scopy biopsy was done by our gastroenterologist, picked up lot of tissue eosinophils. So basically what I'm dealing now here is elevated eosinophil count, which is basically a real scenario which I'm dealing about. And this patient, soon after the marriage, the patient is being diagnosed with this problem. And now that is a 9-10 months back. And now she has become pregnant after I managing this patient. Now she has delivered a male baby a month ago. And yesterday she came with chocolate and gave me this. Basically, it's a real scenario which I'm trying to highlight now. The other scenario is, because the scenario which I was trying to highlight here is blood count is normal, tissue eosinophilia. Whereas here, this patient, similar to the previous one, which I dealt this patient maybe 18 years ago, 70 years old male, a 5 years history of seasonal bronchospasm, and with IV steroids and treated on and off by the general practitioner. This patient from Uddamalpet, and 1 year history of painful peripheral neuropathic symptoms of both lower limbs, admitted with vasculitic skin lesions on both lower limbs with the bilateral lung signs. Basically, this patient is elderly with a long history of bronchospasm, that is lung involvement or airway involvement, on and off relieved with IV steroids. And a year ago, started developing peripheral neuropathic symptoms and admitted with painful ulcerative skin lesions of both lower limbs as well as lung signs. Probably you would have guessed about what the problem is about. The investigation of this patient, low hemoglobin, elevated ESR, elevated total count of eosinophils more than 38%. So peripheral eosinophilia, probably lung involvement, neurological involvement, cutaneous involvement. If you see this scenario, bilateral lung involvement, elderly person, probably we are dealing with a condition, hypereosinophilic status of the peripheral as well as tissue. And it is a vasculitic lesion. What we're dealing with is Chextra syndrome. So basically eosinophilia, the number of eosinophil, absolute eosinophil count is counted by white blood cell count into percentage of eosinophils is equal to the absolute eosinophil count. And more than 500 eosinophils per microliter is to always think about, are we dealing with eosinophilia? Hypereosinophilia is more than 1,500 cells with or without end organ damage, whereas hypereosinophilic syndrome is more than 1,500 cells 1 month apart and dysfunction, organ dysfunction due to eosinophilia. The important concepts when you see a patient with eosinophilia, the count as it is does not accurately predict organ damage. That's the reason I presented two extreme cases where the GA symptoms without peripheral, but completely tissue eosinophilic symptomatic patient. The other one is peripheral also, you're able to identify the problem of eosinophil as well as tissue eosinophils of multiple sites. Basically, understanding is absolute eosinophil count does not accurately predict organ damage, and the degree of eosinophilia may help narrow down the differential diagnosis, but not sufficient to establish diagnosis. All patients with absolute eosinophil count more than 1,500 per microliter should be evaluated 1 month apart, should be evaluated for hypereosinophilic syndrome. The causes probably can refer the standard reference, different reasons for. When you see a patient with hypereosinophilic syndrome patients, always try to subject the patient for neoplastic disorders leading on to the hypereosinophilia. We dealt with the hypereosinophilic leukemia. We dealt with the vasculitic syndromes. We dealt with unidentified causes of eosinophilia, simple helminthic infection-related hypereosinophilia. We dealt with the patient with the HIV infection and hypereosinophilia. So different types of problems which we dealt with. Probably the patient should undergo the investigations of bone marrow along with FIP1L1, PDGFRA and PDGFR beta to be subjected for, as well as rearrangement to be done to find out, is it a proliferative disorder leading on to hypereosinophilia? The manifestations of the different types of eosinophilia, always think about the drugs, which is also one of the reasons. The commonest problem which we dealt is DRESS syndrome. I can share one of the experience with our patient. Maybe 10 years ago, a patient came from Salem. Basically, a female patient managed there in Salem for fever. The historical aspect, probably when I reviewed the patient, because referred here for fever management and sepsis, septic shock. But when we reviewed the complete story of the patient exposed to dapsone maybe 2-3 months ago for some skin lesions started by dermatologists, which the patient took it for a month at the max, then stopped on her own because the patient was not happy with the response of the dapsone. After which the patient started developing fever and subsequent clinical consequences of this fever related reactions, started developing skin lesions, lymphadenopathy. Finally, the problem which we dealt is, it's a dapsone hypersensitivity reaction, which leads to this problem in a long run because patient has been moving from center to center for more than a month. Finally, patient landed up in our center. We could establish the diagnosis, but by the time patient had secondary infections also, which also managed by us. Finally, the patient responded nicely to steroid therapy. Only the take-home message from this lesson, the scenario should be, don't stop the steroids for this type of reactions, especially dapsone. Just got a high concentration, longer concentration of the tissue. Don't stop the steroid in a shorter format. Probably continue for a few months and stop it. It's always response is much better. Just I thought of share this experience when we deal with eosinophilia in a drug-induced problem. So we can get some sort of constitutional symptoms, cutaneous symptoms, cardiac symptoms, respiratory symptoms, gastrointestinal, nervous system, and other system-related problem also you can come across. Now I am admitted a patient with systemic sclerosis, eosinophilia, tissue infiltration into the cardiac tissues. Patient has got restrictive cardiomyopathy. By pyrophosphate scans, completely ruled out any evidence of amyloidosis or infiltration. It's more of suspected to be systemic sclerosis related problem of eosinophilia and other conditions of consequences which we are dealing with. This start of sharing another scenario where we are dealing. So basically, when you start thinking about evaluating a patient with the eosinophilia, always try to look for the historical as well as investigation wise. They should reflect organ involvement. Also try to find out cause of eosinophilia. So both should go parallelly to find out what exactly the cause and what exactly the extent of organ involvement to manage the problem in a holistic manner. Basically, the difference in the eosinophils of the childhood and the adult, you see these multiple granular cells you can see, or granules you can see with the very childhood eosinophils, whereas here it's a hypogranulated eosinophils you can see. what's basically difference between the normal eosinophils of the childhood and the adult. I think I've come to my end of my presentation. So really I was able to convey one or two important aspects of the blood counts, especially apart from the previous presentation. This presentation I was trying to cover up the platelets, the pan-myelosis, pancytopenia, leukocytosis, as well as my interest area of eosinophils as well. Really thank once again the Trichy API, specifically Dr. Shivashankaran sir and Muthamani sir for giving me an opportunity to share my experience as well as thoughts on this common problem of complete blood count. I hope I conveyed one or two important practical tips to all of you. Once again, thank you.
Thank you, sir. Thank you, sir. That was a very useful lecture, particularly for our postgraduates. All the basics of eosinophil, CSR, and other things. And we'll go to the discussion. Anybody want to ask question to Dr. Joy, sir? You can unmute and you can ask the questions.
So can I ask question to Joy, sir?
Please, sir. Please.
Yeah. Sir, from your presentation, I could understand the seriousness of the epidemicity of this problem. Can we have some sort of program in our government side or in an institutional base to have a screening ultrasound for the people like similar to your the colonoscopy for familial cancers? Why don't we have, will that be of any use in a community point of view? Will that be of any use in a community point of view? Because basic available everywhere. I'm just questioning, is only an open question, just a thought process of mine.
It's a good suggestion, sir, actually. At present, the government, national level, central governments, we have formulated that the screening for that. I mean, it's not at, it is at the discussion level. So AIMS and the Delhi ILBS director and the National Institute of Epidemiology. So they have been involved to study the Nafld related the epidemiology. Already they one study got over regarding that the prevention part. So what about that lifestyle modifications and the exercise related the things, and who require actual intervention, medication. So that at national level, the program they have been announced for the fatty liver disease. I think that's it's a central government level, national level as they are starting, and I think it will take some more time to come to the state level. But I'm sure they are going to announce in a big way that related the ICMR, National Institute of Epidemiology, and AIMS and PGI and ILBS, all the centers, the HOD level, they have been involved. But at the state level, if you look into that, actually, what we can do, actually, so mostly these patients in our population look into that, the diabetology, the association, API. So, I mean, because it is not only, earlier the fatty liver was the gastroenterologist or the hepatologist. Now it's totally changed. It is a component of the metabolic system. So the cardiologist has two sonogram and diabetes. In general, all physicians should know about the disease. It is a component of metabolic syndrome, but they have to take a steps forward, identifying the risk factor, controlling the risk factor, and the medication whenever it's required. Regarding the screening, the Fibro Scan, it is, I mean, that's why in my talk I mentioned it is a very costly machine. It comes around 70 to 80 lakhs actually if you're going to purchase. But the pharma companies are coming forward to do the free screening camp at hospital level or clinic level. So until it comes as a big wave program from the government side, meanwhile we can use the services in our patients. We can gather the patients and one weekend or one day, we can screen and we can educate. For that, it's no need of any referral, just whatever knowledge we gain. So that's way we have to treat and we have to follow it up. That's all. You know, they'll come for regular follow. So the same way, once in 3 months, we have to check it, whether the reversibility is there. Or if they're going for a symptom or cirrhosis or HCC, that screening we have to do. If we get that kind of a complication, we have to refer for higher center.
Thank you, sir.
Thank you.
Doctor, 1 minute. I am Raj Shekhar from Kumbakonam.
Yes, sir.
Dr. Jai Varghese, what is the role of metryleptin as there is leptin deficiency in NASH? What's your opinion about it? There is a recent article on the role of metryleptin in NASH. That is because there is a leptin deficiency. What's your advice?
In diabetic patient are you using, sir? Because basic question I wish to ask. Diabetic patient are you using?
We are. And
So
also
the-
what? Yeah. Tell me.
Non-diabetic obesity related Nafld, its role has not yet been proved. But the diabetic people, that's why there's the pioglitazone and this kind of the drugs and GLP and the inhibitor, the receptor. These all are used in the already existing using in the diabetic people. It has its role to control the ongoing inflammation and some sort of a reversibility. But non-diabetic, we shouldn't use. I mean, so far the approval not yet there.
I want to tell one thing. Even in non-diabetic pioglitazones for NASH, are we using? Yes. On non-diabetic pioglitazone. And what about the old drug pentoxifylline in NASH?
Pentoxifylline role in NASH so far, I mean, RCT trial wise not proved. So only the RCT trial, whatever I quoted there is the vitamin E and the PPAR agonist alpha and the obeticholic acid, because based on the multi-center, the things. But other things, the pentoxifylline and the pioglitazones, RCT trial wise, multi-center wise, there are still the recommendations not yet come. But the diabetic agrees.
Fibro Scan routinely at Kumbakonam every month we are doing with the pharma company at Dr. Silvarajan, leading surgeon hospital. Every month we are doing first month Friday we are routinely doing.
So my suggestion, as a fibro scan, if it shows the F1, F2, F3, mostly it is a reversibilities are there. So that kind of the patients, just the identifying the risk factor and the controlling the risk factor, and we have to check the ALT. If the ALT level is abnormal, that time they might require either vitamin E or the PPAR.
Yeah, you have already highlighted. You have presented a very beautiful slides.
Yes,
at the end, you have put a slide.
Yes, if it is a F4, my suggestion better to send for the CT scan to rule out associated any mild splenomegaly is there or not. Sometimes intra-abdominal collaterals will develop, and that patient might require the one-time screening gastroscopy and the tumor marker alpha fetoprotein. So whenever the F4 shows, CT scan and the tumor marker screening at one time, at a first visit they need. After that, we have to regularly follow it up.
Okay, thank you.
Joyce, there's another question is there in the chat box. For which grade of fatty liver fibroscan is needed?
Whenever we are seeing the ultrasonogram based fatty liver, we have to ask the patient to undergo one-time fibroscan, because ultrasonogram will not reveal the grade of fibrosis. It will show fat in the liver, that's all. Fibrosis are dead, so that's why to assess the fibrosis, one is the fibroscan, non-invasive. Another one I quoted, Nafld fibrosis scoring system. It is available in the Google based on the patient age, BMI marker, BMI, etc. I told that. So the fibroscan, if it shows F1 to F4, then accordingly the treatment, as I already earlier mentioned, we have to follow it up. So all fatty liver patients should undergo one time the fibroscan, and how we have to follow it up based on the grade of the scoring system. If the fibroscan that time shows less than 4, then that is called simple fatty liver. So that is, I mean, the disease will not progress. So that time, just the lifestyle modification alone is okay. No need of any medication.
Sir, one question, sir. Is it possible to have portal hypertension and variceal bleeding similar to alcoholic liver disease and cirrhosis in NAFLD?
Yes, yes, that's why. See,
Four.
the portal hypertension, variceal bleed, how it is developing because of the F4 fibrosis or cirrhosis. So this disease, like alcohol, how it is causing that alcohol is also more or less first fatty liver. Then if you do the Fibro Scan test to the alcoholic liver disease, that time also it will show F1 to F4, alcoholic people also. So the Fibro Scan is a tool for not only fatty liver, the Nafld, it is a tool for chronic hepatitis B, it is a tool for chronic hepatitis C, tool for the alcoholic. So those who have, even though patient is well, no much symptom, ultrasonogram shows fatty liver, whether fibrosis, dead cells, whether the dead cells are there or not, this is the tool. So whoever the advanced, irrespective of the etiology, they will, once they go to the F4, they will get a portal hypertension, they will get the esophageal varices, bleeding. Not only that, at one time they will get a pedal edema, ascites, encephalopathy, etc.
Sir, is it advisable to take vitamin E prophylaxis in high-risk individuals?
No, so actually the vitamin E is the antioxidant. So that's why if ultrasonogram shows the fatty liver, even though Fibro Scan that time it shows the less than 4, ALT is normal, no role of vitamin E. Because vitamin E acts as antioxidant, those who have ongoing inflammation, either histological ways, biopsy shows inflammation, or fibrosis shows the fibrosis means it is a sequelae of the inflammation. So that's why the vitamin E is, it's not a prophylactic drug.
Thank you.
Even subcutaneous semaglutide, that is a GLP-1 receptor agonist, has also been tried. 2 trials have been over for NASH, but yet it does not show much significant effect.
Yes, yes, true.
Semaglutide.
Similar to that, saraglitazar also.
Yeah. So many drugs. Diabetes is hypersecretory senescent state due to oxidative stress. But can we give antioxidants to nullify diabetes? We can't. Like that, vitamin E. So, Dr. Saravanan.
Yes, sir.
What about your opinion on thromboelastography and platelet mapping in bleeding disorders? Because if the value is more than 50, suppose light transmittance aggretometry is not available. What's your advice about the bleeding disorders? There is a very recent article by Dibendra Ghosh, hematologist from Jharkhand. He has written a very nice article. That is thromboelastography, platelet map, especially in thrombo.
Yeah, and I have not gone through the article, sir, but even then the TEG, TEG values, especially more useful in perioperative situations, especially cardiac surgery patients, it's more useful. Even in emergency situations of intensive care, medical intensive care, with the bleeding tendency or suspected to be the DIVC situations where can use this K values can be used to decide upon really the patient is going to be really benefited out of platelet factors transfusion or going to go with improvement with the coagulation factor transfusion, especially the FFP or cryoprecipitate can be guided, but it has got towards limited role. It may not be translated into a common practice. Only specific situations of perioperative, especially cardiac surgeries where there's a lot of the bypass is happening with the multiple the artificial machines as well as in situations of medical intensive care. But I have not gone through the article by Dibendra Ghosh. Probably I can go through that.
I have posted in all WhatsApp. I will send it to you personally.
Sure, sir. Sure, sir. Thank you.
And I'm happy. The ESR is a true love width criteria. That is a good marker, especially for ulcerative colitis. And when compared to C-reactive protein, and the CRP is a better marker than ESR.
Yes,
and
sir.
I used to tell, whenever we talk so much about the white blood cells, RBCs, and platelets, we must know the lifespan of each cell. See WBC 4 days, RBC 120 days, platelets 10 days. But without that, we simply stop the patient 2 days, 3 days, antiplatelet agents, platelet. How is it possible? That's why every meet I used to tell whenever there is a talk on this platelet RPs, because 4, 10, 120. That is so simple. Thank
Yes.
you.
Thank you, sir. Thank you. I think
Sir,
there's a
can I suggest one thing, sir?
sure, sir.
Yeah, please tell.
Regarding thromboelastogram, because the thromboelastogram we are using in a liver disease patient, particularly in our liver ICU and during our liver transplantation. Advantage of the thromboelastogram, within 15 minutes, we can come to know what type of the replacement we supposed to give to the patient. Either the low platelet means we can, that related reading comes, we can transfuse single SDP, single donor platelet. If it shows the afibrinogenemia, we can give a cryo. If it shows the clotting factor deficiency, we can give the FOP. So the advantage with us, the day-to-day activity we are using, but the key thing I can wish to tell, in a liver disease patient, particularly the INR will be normally cirrhosis patient will be more than 2 or 3. They will get a blood vomiting, hematemesis. Normally, in the regularly we will give. I also used to give the FOP and the blood transfusion immediately. But that particular patient, if you are going to check the thromboelastography, even though INR shows more than 2. But if you see the curve of that, the thromboelastogram, it doesn't require the patient. So now our practice has changed in our liver ICU based on the thromboelastogram, not based on the INR, not based on the platelet count, not based on the fibrinogen value. Based on the thromboelastogram, particularly this is, I don't know it's applicable to other disease or not, because liver disease, they are more prone to go get a procoagulant factor. So anticoagulant features will be the combination of the things. So based on that, we are using, that's really a good tool, I can say.
Absolutely correct, sir. Similar to that, only the previous days they were using basically for cardiac bypass surgeries, cardiac major surgeries, they were using as a perioperative procedures. Now they started coming up with other transplantations, especially with the liver. It has got a major role in the perioperative phase. Immediately can decide upon what products to be given, should not blindly give. Having come across a low platelet doesn't mean that needs only platelet transfusion. Might be benefited out of the clotting factors, even the fibrinogen replacement. So definitely is a guiding factor, but that cannot be translated into common investigation. That has got its own specific roles to play. In those situations can very well subject the patient for these investigations. Totally agree, sir.
So thank you, sir. Sir, two questions to Dr. Saravanan, sir.
Yeah.
Sir, what is the safe platelet level for doing bone marrow examination? And the next is how to look for tissue eosinophilia, sir. So tell us something about tissue eosinophilia.
Yeah. Regarding the first question regarding the bone marrow examination, I was talking about the low platelet as it is. It's not a contraindication for any invasive procedures. It is the associated conditions. For example, if you are suspecting a leukemia, if you are suspecting clotting factor defect, if you are suspecting some sort of platelet functional defect other than the low platelet, the chance of bleeding is going to be more with even simple invasive procedures like bone marrow. Most of the time, the common indications for low platelet with the bone marrow examination would be bicytopenia or pancytopenia, where the bleeding tendency of bone marrow invasive procedure is very meager. When we have done with at least more than 100 patients or more than 100 patients of low platelet of even 10,000, 8,000 with the bone marrow examination. So it is basically the technique has to be very carefully handled so that you don't get any bleeding tendency out of your bone marrow examination. And the second question is about tissue eosinophilia. It's only by the, for example, the whatever the tissues, it can have infiltrations. Already I was talking about the cardiac tissue or airways or GI tract or cutaneous. So whenever there's a peripheral eosinophilia, you can look for symptomatically or historically, and wherever is feasible, you can subject the patient for to get the tissue eosinophilia. That decides the management. Suppose patient is suspected to be eosinophilia, but the peripheral blood is not showing any evidence, you can very well go for even bronchoscopy to find out what is exactly happening in the tissues, or endoscopy, both upper as well as lower GI scopy can be subjected to get the tissues and see how it goes. Even the cutaneous eosinophilic infiltrations can go for cutaneous biopsy of the lesions where you will get. So basically the answer to the question specifically, the tissue eosinophilia is made out only by biopsy specimens.
Thank you, sir. Sir, one last question to you, sir. Is isolated elevation of ESR needs evaluation without any symptoms?
Yeah, I think I've seen Shankar's question, 3 questions it has got. But ESR alone to be interpreted very, very carefully without any other cellular component. Probably we have to rely on other investigations, especially I was mentioning about the raised ESR or low ESR. Definitely we expect other associated abnormal reports, whether it's a pathological specimen or with a biochemical specimen. That has to be very, very careful. Number 2 is the technical reasons for change in the ESR to be kept in mind to decide upon the interpretation of the ESR. So it is not like always needs, but has to keep all these points, then definitely can decide upon how to go about. The other one is can be age-wise, definitely it has got its own values. So when the age goes up, the value slightly going up. There is no fixed number at the maximum 30, 35 millimeters per hour can go up to the age goes on, but there is no specific number. Number 2 is the female gender is slightly having variations of the ESR, perimenstrual and non-menstrual phases. So it has got its own changes of the number of the ESR based on the gender, based on the age, based on the physiological changes happening in the individual that has got impact on the ESR value. So all these points to be kept in mind to decide upon how to go about with the value, what you are seeing in the patient, whether to evaluate or not to evaluate. I hope I answered the question.
Sir, thank you, sir. Sir,
Thank you,
one question to Joy, sir, apart from the topic. Sir, approximately how much will be the cost for one liver transplantation, sir, for in your center if you want to send some patients, means how much is the cost?
Actually, the cost for the liver transplant now comes as a package. Actually, it's a 19.5 lakhs from the day of operation to discharge. Usually, they will get discharged in the 2 weeks' time. Okay. This package includes the donor operation and patient operation. But now the Tamil Nadu government has incorporated, not now, earlier itself it was there, the scheme. Those who have belongs to the low socioeconomic status people, those who have these chief minister's health insurance scheme, if they have the card, they no need to pay this 19.5 lakhs because from the day of operation to discharge, it's entire the amount is taken care by the government of Tamil Nadu. And not only that, after the surgery, 2 years, post-operative 2 years, the medical expenses that includes investigations, and the investigations, in case if they require any admissions, that also they will cover. So the low socioeconomic status, those who have the CM health insurance card, they can use it. There is a process. They have to get the clearance from both the DME and the DMS office with all the proper document. But the government is giving mostly. Now we are doing the pediatric, we have done more and adult few, but
Okay, sir. Thank you, sir. And I also thank Dr. Rajshekhar, sir, for sharing his valuable ideas in this forum.
One more point I want to tell.
Yes,
There
sir.
is also one latest platelet mapping method is called light transmittance agglutinometry. That is LTA, light transmittance agglutinometry. Is also another latest method. Thank you, Dr. Saravanan,
Thank you,
and
sir.
all the organizers of API Trichy.
Thank you, sir.
And Saravanan.
Thank you, sir.
And
Thanks, Rajshekhar.
so I call upon Dr. Prabhu for giving the vote of thanks.
Good afternoon, all. On behalf of APA Trichy chapter, I would like to thank Dr. Joy Varghese sir from Global Health City for sharing its knowledge about a silently increasing worldwide disorder, non-alcoholic fatty liver disease. And also I thank Dr. Saravanan sir from PSG Coimbatore for his excellent talk over sample collection, CBC reading, along with some interesting clinical cases. And last, I would like to thank participants for their active participation. Thank you.
Thanks, sir.
Thank you, sir. Joy, sir. Thank you, sir.
Sir.
Thank you.
Hey, Rajshekhar, thanks.
Thank you, thank you.
Active participation.
Saravanan, sir. Thank you, sir.
Thank you, sir.
Thanks, sir.
Sir, Joy, sir. Thank you, sir.
Thank you so much, Dr. Muthu.
Thank you. Thank you.
Thanks, Mani.
Sir, thank you, sir.
மீட்டிங் அடுத்தது
இல்ல சார், ஒன்றும் இல்லை சார், மீட்டிங்லாம் எதுவும் இல்லை சார்.
அசோக்குமார் சார், ஐயா அசோக்குமார்
அவர் மியூட் பண்ணியிருக்காரு சார்.
நல்லா அப்படி மூஞ்ச காமிங்க, தலை தான் தெரியுது.
தலை தான் தெரியும், அப்புறம் என்ன தெரியும்? இப்ப தெரியுதா?
நல்லா தெரியுது, ரவுண்டா. நல்லா இருக்கீங்களா?
தெரியுதா?
நல்லா இருக்கீல்ல?
தெரியுதா?
நல்லா இருக்கு, நல்லா இருக்கு.
ரைட். Thank you.
Thank you.
Thank you.